All right, thank you, Dr. Morris, and thank you all for being here. It's a lovely occasion. Mark just left very big shoes for me. So, in full disclosure, I do not have any multimedia or other entertaining things to share with you all, unfortunately. So that's the gift and the curse of following such a phenomenal speaker and doing incredible work. I was making a lot of notes myself about how we can enhance the work that we're doing here in St. Louis. So really grateful for the opportunity to share really sort of a midpoint in our study, the ARCHES study. So that's why it's called Notes from the Field, what we're doing right now. Mark mentioned it, 17 years of effort. We're about 3 years in. So a midpoint in our study. And so what I'll talk to you first is about our overview and rationale that aligns with many of the things that people have said already today. We'll talk about some of the community engaged principles that we employ, and also try to give you a little bit about some of the promise and the perils of some of the implementation of those principles. So before I start, I also want to acknowledge team members, some of which who are in the room. Of course, Ganesh, who's a co-PI on this and does phenomenal work and outstanding collaborator. Alexis Walker, who's our main lead for this project on the staff side. Sammy Murphy and Christian Banks, who are outstanding research clinical coordinators. Also, people who've contributed to the project, like Carl Hill, who's an old classmate of mine back in Michigan, JF Traney, who helps us with our community model building, which I'll show you in just a little bit. Also, our community advisory board members. Oftentimes, those folks are sort of the unsung heroes, as Mark pointed out there, so I wanted to acknowledge those folks. Also, our data safety and monitoring board members as well. Dr. Morris and team for bringing this outstanding group of researchers together. And then, of course, our anonymous participants who, without their contributions, this work would not be possible. So lots of acknowledgments. I always like to start with thanks. So thanks to everyone who's made this project possible. So here's Ganesh and I, and we look pretty handsome there, I would say. This is what we typically look like. So I like to look back at a photo like this to remember this is indeed what I look like most of the time. But oftentimes when we're texting after hours or chatting after hours or talking on the weekends, this work is really challenging to do. So we'll talk about that a little bit more as we go along. So the rationale for this study is, of course, as we've talked about today, Black Americans have higher risk of developing Alzheimer's disease and related dementia. However, of course, there's not enough research that focuses on Black Americans. So we're recruiting, like Mark, exclusively Black American sample here in St. Louis with the goal to examine risk factors. Those risk factors largely centered on mental health, stress, and social determinants of health. So our goal is to develop a cohort. We're hoping to follow these folks over a longer period of time, so we have a slightly younger start point at 45 years or older, again, in the St. Louis region, and we're following people over 4 years. We're also looking for people who are normal cognition, and we're really trying really hard, which is difficult, to get a representative sample across socioeconomic and spatially. So thinking about where people live. St. Louis is an interesting place in that it's so close to not just the suburbs, but also rural areas. You can get to rural areas not far from here. Just a 30-minute drive will take you into southern Illinois or out into the sticks in Missouri. So thinking about some of the dynamics that are here in St. Louis is important. So that's our goal, and we want to collaborate with community partners. So that includes our community advisory board, in addition to others in the broader St. Louis community to do this work. So I'll talk a little bit about that in just a moment. And our work is guided by the NIA Health Disparities Research Framework. An advantage of this framework, of course, is that it's a multi-level framework. So you're thinking about individual all the way out to societal issues. We're also thinking about how we can measure these factors. So environmental factors, social cultural factors, behavioral and biological factors. And we think that it's important to have that framework to censor all these complex problems and factors at the same time. All right, so some key study components. We do a one-time blood draw for participants at baseline. There's an optional MRI scan. We're looking to recruit about half the sample into that, so about 150 participants. We do a cognitive assessment at the beginning of the study, and participants also have the option, which I'll talk about in detail in a moment, to participate in a workshop. So this workshop is really neat. I really enjoyed that part of the study, much more than I expected, so I'll tell you about that in just a moment. And of course, completing a pretty comprehensive questionnaire, trying to get everything under the sun that you can give to a participant without absolutely overwhelming them and totally making them go away. So those are the key study components. So as mentioned in the title of our study, centering on health equity. Health equity, of course, means that anyone, regardless of their ability, identity, or other socially related factors, can achieve the highest level of health at their level. So in order to advance or strive towards equity, we have to think about centering on people who often have been excluded or marginalized. So we want to make sure that we bring people to the table who have expertise and their own lived experience. And so for us, thinking about people, Black Americans in St. Louis, who have a lived experience that they're experts in, they can inform us, and hopefully that'll make some strides towards health equity. So many of you have probably seen this table from the Centers for Disease Control and Prevention that talks about different levels of engagement. So ranging from outreach, which is more voluntary types of opportunities, all the way out to shared leadership. I would say we're probably in the involve and collaborate area, where we're trying to engage in bi-directional communication between the community and our advisory board to get their input on what we're doing. There's my multimedia, by the way. That's to make sure people are staying awake. So the idea is to have bi-directional relationship. Hopefully that builds trust over time, so we're not just talking at people and telling them what we want to do. We're hearing what they want us to do and taking in their feedback as well. So the implementation of community-engaged strategies, which people have talked about, Mark did a great job of highlighting theirs. We also have a community advisory board. One of our main goals was to make sure that board was representative, meaning that we had Black Americans and people who do service provision in the community, making sure that we had people in housing and other services, senior aging services that were at the table. So we want to make sure we have the right composition and offer diverse perspectives across a wide range of sectors, disciplines, and lived experiences. Again, one of the biggest things that we wanted to do was to make sure that we have people at the table who do provide service to our population of interest. And oftentimes we're looking for connections that quote unquote string pearls. So one of the community partners that I work with here in St. Louis, who's the executive director of the Empowerment Network, which is a prostate cancer awareness organization, came up with this phrase on another project that we work with, but I thought that was so fitting. There's so many pros in communities like St. Louis or wherever you might be from. And oftentimes those people do not talk to each other. They're doing similar work, they're talking about the same issues, but they don't know that each other exists. So a lot of times we find ourselves trying to facilitate connections, and so that's something that's been neat about our community advisory board, seeing the synergy between people who are working in similar spaces. We also compensate our board members, or our community advisory board members, for participation. We often lean on them to direct our efforts. This includes our recruitment efforts, also thinking about innovative ways that we should be thinking about, like recruiting in the radio station or coming up with ads to put on the public transport system here in St. Louis. And the goal with this is not just for this project, directing our efforts here in this project, but ultimately to have a long-term sustainable partnership to build upon our initial research. So hopefully one day we'll be like Mark in 17 years or so. I'll have even less hair than I have right now. I can come and share the results of what we're doing here with ARCHES. So another thing that we do, community engagement, again, going back to that CDC table that shows different levels of engagement. One particular part of engagement is participatory. So you can involve people in the actual formation of research questions and thinking about from the ideation phase all the way out to the dissemination phase. And so that's something that we've tried to do, is to get people involved in the work. So not just dance parties, but thinking about how can we get their input in formulating the questions and answering the things that we're truly interested in. So one approach that we've used is community-based systems modeling. So over a period of 5 days in the spring, we, with 59 of our participants, ended up doing these workshops that were really neat, and this is what the workshops look like. We brought people in all day on Fridays and Saturdays. I couldn't believe that people participated that long, but we fed them, of course, and people were happy to do it, and people wanted to find out how can we contribute to healthy aging in St. Louis? How can we reduce inequities in Alzheimer's disease and related dementia? So we have these neat wink boards around campus here where people can go in and write factors on the board and talk about the factors that they see that either are barriers or facilitators to healthy aging or perhaps the development of Alzheimer's disease and related dementia. And so with the sum of those efforts, this is what the community-based systems model looks like. And so we're in the process of analyzing the data there in order to publish those and show, again, what are some of the barriers and facilitators to healthy aging within the St. Louis community. As mentioned before by a few presenters before me, we started with intentional dissemination plan at the very beginning. So we weren't thinking about dissemination at the end. Obviously, as I mentioned before, we're in the middle of the study. So we're thinking about what can we do to feedback our results, not just for the purposes of publication, but also to make sure that participants feel like they're involved throughout the process. So again, as Mark said before, through newsletters and participant engagements, et cetera, those are ways that help us to stay engaged with participants, to build trust, and also serves as an avenue to recruit. So I'm happy to see that some of the tactics that we use align with others that I've presented today. So the word of mouth avenue is really important. We can also provide information not just about the study, but we can also provide connections to services. So at one of our events, we had tables set up sort of like a health fair style, where people can come in and see different agencies across town who offer different types of services that they might be interested in. So this was a truly interdisciplinary approach, and we also had an open Q&A. So this is what our spring participant brunch looked like, which was our first of hopefully many that we'll do to feedback results, where we had over 70 participants come, including our guests and participants and their guests and community partners. And so we have some speakers, including Carl Hill and Dr. Lisa Cummings-Vaughn, Dr. Monique Williams, and we had community partners, including members of our own community advisory board, come in to talk about the services that they provide to people in the broader community. One thing that was really neat at the end of that was that Dr. Cummings-Vaughn gave a presentation about aging in general, talked about Alzheimer's disease and related dementias related to Black Americans, but then there was just an open dialogue, open question and answer, where people got to ask anything under the sun related to ADRD as well as to aging. So that became a connection point where people got answers, not just us taking from them, but there was some reciprocity involved there as well. All right, so as mentioned before, just showing up. So countless hours. Just the other day, I'm looking at Christian now. We were at a men's health fair in North City, St. Louis. I had my 10-year-old daughter. She was dressed in her cheerleading outfit because we had a cheerleading event right after this. She had to go cheer at a game. And so you end up spending a lot of times all over the place. That includes weekends, evenings, holidays, and you're trying to coordinate all these events. And there's always something that you're not attending. There's always something that's happening either simultaneously with something that you've got going on or something that just went under the radar. So sometimes it can feel like you're spinning your wheels. But I would like to think that through the continued efforts, I would say, to engage with people over a long period of time, you'll get a chance to build up trust. You'll get a chance to raise awareness of our study, of who we are, to know that we're not here just to helicopter in and take out data and never come back, that people see and get a good feel for who we are as people, human beings, as well as, like as Jonathan mentioned, we're people too. So I think it helps to come in with that. I'm from a community like yours. I'm from Detroit. These are things that have affected my family. I could talk about folks in my family. I could talk about why this work is important, and that becomes another human connection point. And again, you're hoping to build trust. And I would say for people in the room, especially folks who are either junior or even mid-career, is this something that's valued at your institution? I think if you think about from a barrier to participation in things like this is something that many people who are thought leaders or leaders in general at their respective organizations here in the room should ask yourself, if you want people to do this type of work, how do you incentivize that work? How do you make it possible for people to spend hours on the weekend? That's not a publication, that's not a grant, but that's the work that's necessary to do it. So we have to think about a way to make sure those things are rewarded. So a lot of times we end up meeting people where they are, again, whether that's the MetroLink here, showing up with flyers around town. So a few other things to note about community engagement. Again, some advantages here are that the best strategies for ameliorating inequities and especially social determinants of health are those that reflect local knowledge and a community's readiness for change, not just expert knowledge from people from the outside. So the inclusion of those who experience health inequities in all aspects of our work means that we have to find ways to identify and engage all subgroups affected by health inequities and provide opportunities for people to fully engage once they're at the table. And I will underscore that. Oftentimes we say, let's bring people to the table, but what do we do to prepare people to be at the table? I know that's a rhetorical question, I don't expect people to answer, but if you ask people to show up at the table, how do you prepare them to participate? Sometimes people will just be polite, and there's a power dynamic that oftentimes we don't like to acknowledge with big institutions like WashU or other places around the country. So how can we prepare people to participate? And also, what can we do in terms of development of sustainable skills? So how can we organize and build up our community partners that we're working with? So some additional challenges to consider. Obviously, this work is no panacea. It takes a lot of time. I would say another factor is personnel. I don't know about you all. In my PhD program, I didn't learn how to manage people. Did others? Oh, good. There's one person out of a sea of folks. So I never learned how to manage people, hire people, have difficult conversations with people, et cetera. So that's something that's really critical, especially when you're hiring people from the community who might have a voice. So if you have an awkward or unpleasant interaction with people, and they will happen because human beings are, no matter where they're at, whether in academia or in the community, they're still people. And so there's a lot of potential for clashes. So how do you navigate those clashes? How do you navigate difficult personalities and make sure that your team, who's working on the weekends, working in the evenings, going all over the place, doing all sorts of things that are not compensated, how do you make sure that you maintain that critical team chemistry while also interfacing with a bunch of people? So institutional support, as I mentioned before, is critical for this work from whoever the respective leaders in your institution might be. For us, it might be a dean or a provost, a chair, or some other administrative leader. It's also critical to make sure that you have the right community partners and make sure, again, that you prepare community partners to participate at the table. And of course, funding is always a challenge. There's never enough money. There's so many things that Ganesha found, and I found that we did not anticipate that we needed. Sometimes community advisory board members will say, let's have a radio spot. And the radio spot might cost $15,000, which literally happened to us very recently. So we're like, where do we get $15,000 from that we did not anticipate in our initial budget? So another challenge is oftentimes funding alignment. We're often taking a research problem or question to a community and saying this is what we need to work on. But again, if you think about that continuum that the CDC Guide for Community Engagement thinks about, how many opportunities do we have to hear what people think is the problem and then act on that? So oftentimes our funding mechanisms don't account for what's organically happening in communities and how we can act on those things. I would say despite all the efforts that we've made, recruitment is still a challenge, especially our sample composition. So who's not there? Men, like myself, are really difficult to get at. So shame on people like me. And we've made a lot of efforts to recruit men, thinking strategically, thinking about Divine Nine organizations, one of which I'm a member, trying to think about what can we do to connect with men. So that's still a challenge. Also, as a trend with many other types of work in this area, our sample certainly trends towards higher educated. So how can we make sure that we get more people who are lower educated, lower income, live in different areas of the region, as I mentioned before. So those are a few challenges. I can go drone on and on about many of the challenges, but I'll turn things back over to Dr. Morris, and thanks for your attention. Looking forward to the discussion.